Well, first of all, welcome to the 22nd Annual Ppmd Conference. I'm really thankful that you're all here. Our very first conference was held in Orlando long ago at a Hilton hotel. And during that conference, we were a very small group of parents with Eric Hoffman and Terry Partridge, and we sat together, and they thought we were crazy, and we thought they were crazy, and we thought that craziness could become a family, and it did. So in Ppmd, we think about every single day, every single one, every single boy, every single girl, every single family, every single sibling, every single grandparent, every single clinician, every single researcher, and every single company that's involved. Every single government person, agency that has been supportive, every single one matters, and matters a great deal to us. This is interesting. Thank you. I knew it was the forward button, but I didn't know. Okay, let's see. So, somebody asked me who's here. So we wanted to show you a slide about who is here. You can see here that about splits in half in terms of families, teens and adults, with researchers, clinicians, and industry. So we're about 50-50. And I think that if we think and reflect back to when we first started with only a few parents and just 2 researchers, we weren't a big family, we are now, and I think when all those voices can be heard and heard together, that's when magic happens. And I think in this field, magic is beginning to happen, and I'm really pleased about that. I'm going to come back to this later. So I wanted to talk to you about what we do and how we think about what we do. So we try to look very comprehensively at Duchenne. We look about how we can help improve diagnosis. We look about how we can improve care and make sure that everyone has access to good care. We want every single person involved. We want families. We want therapies. We want access to those therapies. We look at this as a race: research, advocacy, care, and education, and we feel that those are the pillars and combinations with which we need to attack Duchenne to try to drive therapies and make sure every boy can live out his dreams on this earth with his family. So, to think about newborn screening, Annie Kennedy, who's here in the audience and one of our amazing staff members, and one of my dear friends, is working on newborn screening. And she and a group of people, which consists of a steering committee and loads of people under that, and Jerry Mandel is working with her, and he is here as well. Newborn screening is really going to be important so that there will be a day when babies are born, they can be rapidly diagnosed and rapidly treated, so that Duchenne will end for those young ones at birth. We have an international registry. This is called Duchenne Connect, and if you're not in Duchenne Connect, it's important that you consider joining Duchenne Connect. This is a patient-reported registry. It's curated by some amazing genetic counselors, and Ann Lucas, Ann Martin. We try to get everybody the same name in the organization, it just seems easier. And Lauren and Jennifer and Matt are all involved in the registry. And just to show you its reach, it also is funded by Purlong, so it is one of the patient-centered outcomes research Institute has given grants, and this is part of that looks at big data sets. And Purlong is really an important aspect of the support for this. The mean age of diagnosis in our registry is age 4 years old. This registry has participants from people all over the globe, as you can see. So I think it's really important for us to think about how effective this registry is and can be. And by the way, we just are now established and signed a contract with Australia. So Australia will have its own portal, patient-reported outcomes, and they will be looking at and getting into our database, and then we will have the aggregate data. We have a Decode Duchenne program, which means that young boys who have barriers, or young girls who have barriers to clinical diagnosis or genetic testing can have their genetic testing at no cost. We work with Emory Genetics, and this is where we get their genetic testing for free. So these are people with barriers, whether that's old testing, whether that's insurance barriers, whatever the barriers are, we offer free genetic testing. So that is fundamental in the diagnosis to know the genetic basis of the disease. When we think about care, we look at it comprehensively because this is really, really important to have comprehensive care. And this is important not only for the health and well-being of this young man and some young girls, but it's very important for clinical trials so that care is consistent. Because if people are being cared for with different interventions at different times, then that can confound clinical trials. So having a good foundation in care to preserve and protect what muscle is there and really think about the quality of life and then participate in clinical trials if you're willing and available, that really makes for a much more rigorous clinical trial. Kathy Kinnett, another wonderful staff member, is here, and she has developed and leads the program to certify Duchenne care centers. Why is this important? It's important to have consistent and good care and to be confident that the physicians you are seeing, the teams that you are seeing, are providing the best care and treatment possible. There are now 11 centers with 17 pending who have applied to us to become certified Duchenne care centers. And this is critically important, we think, for the overall health and well-being. And also some of these centers will become our clinical trials networks. The idea is that as a parent, you shouldn't have to travel thousands of miles to get good care. It should be near you, and that's what we're trying to do. So the feminine side of Duchenne. I don't know how many of you are carriers in here. I'll say to you that I am a carrier of Duchenne muscular dystrophy. My mother was not, so I was a carrier when I was born. And I didn't know that I was a carrier, and then my two sons were diagnosed, at which time I found out I was a carrier. And later, many years later, I found out that my daughter is a carrier. One is and one is not. So we wanted to understand this a bit more, and I think that this could offer insight into the disease. So Ppmd recently awarded Nationwide Children's a grant to look at the feminine side, and not just the heart. We believe that there is a risk, an unknown percentage of risk, for female carriers to have heart disease. But what we also hear from moms and talking to them is these moms had some muscle cramps when they grew up. Some moms talk about weakness. So this is a program that Jerry's going to talk about a little later that's going to look at 4 areas. One is stress, the second area is cardiac, the third area is skeletal muscle, to understand its weakness, and those to understand the girls with Duchenne, and to make sure they have access to therapies and treatment, and also to look at some of the cognitive aspects to see if some of the behaviors we see in the boys could be present in carriers. So this is a comprehensive study. It's going to be 300 women, the feminine side of Duchenne. You're going to be hearing more about that. We also engage the adult voice. Again, Annie Kennedy leads this program, and this is really our path. The Ppmd Adult Advisory Committee, several of the members of this advisory committee are here. We are listening to a voice that when we first started wasn't present because the boys didn't live that long. Now we have young men graduating from college, getting married, doing stuff, being employed, and we listen to their voice. And as you know, sometimes our children don't really necessarily have the same view as the parents. And so we feel that that's really important to know. Sometimes we won't like it, but nevertheless, it's important to know. So robotics, and I hope you go through the display out there. We've been investing in robotics for the last few years with Solid in terms of their Solid suit, but also with Arjun and the Flex Tension folks from the Netherlands who are also here. And also we just awarded a grant to New Jersey Institute of Technology, which is in combination with Talem Technologies. And this is looking at an arm support that would really augment the arm function for young men who are no longer moving or no longer walking and their arms are losing function. So the use of robotics in all sorts of areas of life are going to be very important, and we're really happy to be working with all of those folks that are involved. Now to the research aspect. Duchenne is well characterized. It's pretty amazing to think about. Right now today there are more than 40 companies looking to replace dystrophin, whether that's with, or get it expressed, whether that's antisense oligonucleotides, or replace it with utrophin, another protein that could act as a substitute, but also to look at things like gene therapy that are coming along. We have several companies involved in gene therapy to replace a smaller gene, a mini gene, but to do systemic gene therapy, something we only dreamed about many years back. And then all the companies that are interested in building muscle, preventing fibrosis, improving circulation, all of the downstream possibilities, improving the mitochondrial function. When we look at this and we think 40 companies working on Duchenne, it's pretty spectacular. This was a barren field when we started out. So these are the current clinical trials, and I'll say to you, and I think you all know, we've had some setbacks this year. Some of the trials, BioMarin's study has been pulled, the tadalafil study was a setback, PTC. So we're learning. My mother used to say to me, love and learning are things you can never waste. So in all of these studies, while they're a setback, we learn from them, we ask questions, we design better trials, we get better therapies at the end of the day. So as hard as it is to feel a setback, it is temporary and will not deter us from going forward more rapidly. So Ppmd engages with companies. We try to serve their needs. We try to provide them with what they need and what they want. And often that might be as far as looking at our database in terms of Duchenne Connect. That might be looking for a specific mutation. That might be understanding care and looking at our care centers. That might be discussing a protocol. That might be discussing a regulatory path forward. So we really try to do our very best to fill the gaps in, to move this community and this process forward so that there will be a day soon where all boys will be treated. So again, I mentioned, here's another issue that we're trying to tackle. There are 40 companies. I'm going to say that 1,000 times because I'm always thrilled and amazed by a day of 40 companies investing in Duchenne. When we started, zero interest. So now, many of these protocols, as you know, are between 7 and 13 years old, or 7 and 15 years old, often ambulatory. And there are sub-studies in some companies looking at very young boys. Not many studies looking at adults with Duchenne. We have to look at adults with Duchenne because you can't imagine being 17 or 18 years old and being outside the window. So really designing trials that are inclusive, and how can we get there? How can we think about doing that? What biomarkers can we discover, protein signatures? How can we fill those gaps so that everybody has the chance to participate and the opportunity for access? So we have a drug development roundtable. This was established several years back, and this is when all of those companies come together and we discuss things and important issues for them that they wish us to cover. There's a steering committee as listed below, and one of the issues that came out of this meeting last year was the need for pulmonary outcomes. So Ppmd, Kathy Kinnan organized a meeting with 50 specialists to look at what are pulmonary outcomes, what would be relevant in terms of an outcome measure for a clinical trial, which would enable adults to participate. And certainly we've done that, and that was a terrific meeting that you're going to be hearing about that. We also did a bone health meeting to think about bone health in Duchenne muscular dystrophy. You all are aware that in Duchenne, the bones are a little more fragile than in healthy children and become more fragile with the use of steroids. So how can we manage that? What do we have to look for? What should we concentrate on? What's the best intervention? What's the best drug? When do you use it? Under what circumstances do you use it? The bone health meeting again, 50 specialists came in to discuss those particular issues and how to measure. So we're back to every single one. This matters. Every single boy and every single girl that's a manifesting carrier matters to us. Advocacy. We work on federal advocacy and have done this almost since we began. We went to the NIH very early on when we started and said, what are you doing? What are you investing? And they said nothing. That led to a bill called the MD Care Act, which was passed and signed into law in 2001, reauthorized in 2008, and again in 2014. And by this time, a $500 million investment in Duchenne muscular dystrophy. So we've been able to leverage considerable money through the Department of Defense, the National Institutes of Health, and the Center for Disease Control. So advocacy matters. Your voice matters to all of those who represent you in a Congress that sometimes doesn't make sense. It makes sense when it comes to research for Duchenne muscular dystrophy. So these are just some photographs of Michael Gaglianone, because it's a family that does advocacy, and Michael is often with us on the Hill as we talk about the importance and the relevance of the investment of the federal government into advocacy. So we talked about this, some setbacks that we've had. But we also have a regulatory agenda that we've been working on. One is benefit risk, and Ryan and Holly PA lead the benefit risk. We were the first organization to provide the FDA with benefit risk, a small pilot study that demonstrated that the highest priority of families, of parents, is slowing disease progression, the highest priority. And you're going to be asked to take a survey here. I hope you do take this survey. Benefit risk is important because we're in the area of patient-focused drug development, or PFDD, because everything in Washington has an acronym. It's like a rule. And I think if you get an acronym, you get an institute, but I'm not really certain on that. But it's important to look at benefit risk because at the end of the day, when there's a therapy that your physician is discussing with you, it's about benefit risk. It's about what benefit you might get, what risks you're going to take on, what is unknown, what uncertainties exist, and whether that is acceptable, whether you can get insurance to cover that, whether the out-of-pocket, should there be any, is manageable, and whether it fits into the context of your life. So it's all about a benefit risk. We also wrote draft guidance for the FDA in 2014. We were the first ever rare disease group to submit draft guidance, and that turned that ship around, and in 2015, the FDA, issued draft guidance. We were working on patient-reported outcomes. We want to know what matters to patients, because if it doesn't matter to you, you're not likely to take whatever it is, the therapy that's recommended. We're working on a paper on combination therapies, because right now, with lots of options, lots of opportunities for trials, it feels like you might only have one option in the course of many years. So we want that to change. We want companies to work together. We want to think about what combinations make sense and how to get them to you as fast as possible. So the combination therapy paper will come out. It will be a platform for advocacy, and we will move forward. We're also working with FDA on other issues. You'll hear more about benefit risk. All of these are important, and in terms of the regulatory policy of how you get drugs approved, what makes a meaningful difference, and how important your voice is, and your son's voice is, and all the adult PAC members' voices, and every person in this community's voice is important. This is about the Cures Act, again, advocacy. So sometimes we think about what goes on in Congress, and it's kind of complicated, and certainly we can't even talk about the election, so we'll put that aside. But I think it's really important to know that there are pieces of legislation that are relevant and important. 21st Century Cures is one of those. It is about infusing the patient voice into the regulatory process, and it's very important that the patient voice is there. Rare disease is tough. There are fewer patients. Sometimes in the course of a 48-week trial, we don't know. We think some people are better. We're not sure. It may not meet its primary outcome, so we may have to wait a little bit longer. I think we've learned that in the advisory committee for Sarepta, that it took a couple of years for us to say, oh, those boys are doing differently. So I think it's really important to pay attention to legislation, even though it sounds boring, and even though Congress and their antics are difficult sometimes to interpret. But to sign on and say it's important is really important for you, for your family, and for every boy with Duchenne. So this is the 21st Century Cures Act. It passes the House. Now it's Medical Innovations Package, and if you don't remember Civics 101, the House passes a bill, the Senate passes a bill, and they get together and make a consensus bill, and then finally it's overall passed and signed into law. We're not there yet. The Senate's still working on it. And included in the package is FIA. This is a provision we worked on, patient-focused impact assessment. And this provision is something we think is really important because what it requires the FDA to do is give us a little report card about how they made a decision. When they've approved a drug or not approved a drug, what was included? Did you have benefit risk? Did you have patient-reported outcomes? How did you make that decision? Was it only based on a single outcome measure, and maybe that's not sufficient to have a real clear picture of what this drug could or could not do for patients. So again, the PFIA is about tools. It's about giving the FDA some regulatory tools with which to be flexible and add their flexibility into the decision-making process. Because rare disease is hard, fewer patients, and we may not know in the context of 48 weeks exactly what impact that will have over a lifetime. So we've had 3 congressional briefings about this. I think it's important to talk about it. I think it's important to get involved in advocacy. I would have never guessed a single voice counted when my sons were diagnosed, and now I'm a complete believer, and I've certainly joined the church that says we can influence legislation, and we should. So, this is, again, targeting rare disease therapies. This is really another important aspect about FDA's discretionary authority to expedite development. This is something, again, be informed, sign on. It's important, and it only takes a call from you to your congressional offices or an email to them. And I think when you're doing that, you must remember that it's not just a one-time, here, I support this. It's about a relationship. And you can do that on the phone or in person, or when your representatives are in their hometown. It's not a bad idea to show up face-to-face with the people you care about, the son that you love, and say, this matters to me, it matters a lot. They won't forget you. Always remember to say thank you, because that establishes a pretty good relationship. So we have transitions. There are policies that go far beyond the Congress and the regulatory, and this is transitions. The transitions about becoming an adult, but also in policy as adults. There are limitations. If you have a job and you're making a certain amount of money, you can lose services. So we need to address and attack some of those policies to raise the threshold, because as we get these lawyers and people getting really amazing jobs in their lives, they should not be restrained to be unable to have a full-time job based on the loss of services. So Flextension is here. This is one of the robotics folks. Please look at the poster session and all of the displays outside. These are all people that are trying, companies that are trying to make robotics that make life as a non-ambulatory patient or non-ambulatory person easier. So I think it's really important to pay attention. Solid Suit is here. The XR arm is here. These are the robotics I talked about. I think you should be familiar, understand where they're going, where they are in the timeline, and what that might mean to your family. So coverage and access, again, Annie Kennedy, I think she actually really lives in Congress. I'm not certain about it, but she seems to know everybody in Congress and who's doing what for whom. Once we get these therapies online, it's really going to be critical to make sure that they are accessible to all, everybody that is amenable to the therapy, that they are covered under insurance, whatever insurance is, and that the out-of-pocket doesn't bankrupt any family. So these are the things that really make us spend time and thought, and Annie lived in Congress. So this is about a continuum, right? This is about making sure that a good, accurate diagnosis, excellent care, participation in trials, access to therapies, coverage for therapies, and an improved quality of life, and not the life you worried about when you first Googled Duchenne muscular dystrophy. So this is about coverage through Medicaid. Annie is working on this. If you have questions, you need to speak to Annie because she is the one who knows. I'm really calling on you, Annie, a lot. So these are things that you can do. Things that you can do. So when Annie calls you and asks you for a story or a voice, please raise your voices for us so that in the end of the day, access is available to all. Because I'm getting flagged, I'm not going to go over all of this. But just know that advocacy is really, really important. We're trying to understand them. We're working with health economic models to make sure that the insurers know that even a little benefit is terrific and valued and necessary for all boys with Duchenne. So at the end, we do marathons. And if you're a runner or if you're not, and I'm not, but I run marathons. I don't really want to run, I walk. But I think doing something is better than sitting worrying, because together we've made an incredible difference and will continue. We're a strong community and we're capable. And in this room, clinicians, researchers, companies, families, grandparents, aunts and uncles, siblings, everybody is here to make a difference. We can make magic in Duchenne. We can make sure that there are treatments available. This is about every single one. And I'm going to back up and just tell you a story that I wanted to tell at the beginning, but we have a guest here. So our first conference was in Orlando. It was at a Hilton hotel, and there were only a few of us there, and we all kind of sat together wondering what we would do. And no one actually knew what to do, to be fair. And I certainly didn't know anything about running a nonprofit foundation, and neither did they, so that was helpful. We felt pretty isolated and alone, We had a gene and a protein product, and we wanted to stuff it back in some way, somehow. We didn't have those tools available. And there wasn't much money in this field. And as Ppmd started out, we had zero money. And to be fair, we made some promises to Eric Hoffman about giving him money, and also UCLA about giving them money. And we didn't have any. So there was a man who stepped up and said, I'll give you money. And the first check he wrote to us was for $100,000. So he wrote us that check 22 years ago because he had a grandson by the name of Jance, and Jance had Duchenne muscular dystrophy. So I'm going to see if I can go back. Can I go back to the first? There. So this is the Jackson family. This is Jimmy Jackson, Sherilyn Jackson, and their son Jance. These are two portraits that we have that will be hanging in and rotating through some of the clinical care centers. This is the family who started Ppmd. Their grandfather, V.H. Harmon, is the one who wrote a check to me. I think this was a leap of faith on the part of V.H. Harmon. He's here today, and I would like you all to know we're giving him an award, a legacy award for doing this. I won't make you come up, V.H., I'll come to you. And Donna, you can come up and get this for V.H. So this just says, thank you to V.H. I'd like you to give him a round of applause.